Good evening, everyone, and welcome to the webinar on the theme Hodgkins Lymphoma in 2026 from Research to Practice. It gives me great pleasure to invite our Program Director, Dr. Tulika, Seth, Professor of Hematology, All India Institute of Medical Sciences, New Delhi. Over to you, ma'am.
Thank you so much. And this is a really interesting and very important webinar. We've all been treating Hodgkin's lymphoma for many, many years. And I think it was one of the first malignancies 30 years ago when we all started really treating oncology that most hematologists and oncologists were very comfortable with. And we were quite happy with our frontline therapy. Unfortunately, many patients relapse and become refractory and then become very difficult to treat. So it's with great pleasure that I invite Professor M.B. Agarwal to talk about this condition and where are we now. Sir is a legend. He's professor of and head hematology at Mumbai Hospital, Mumbai, which is a very small introduction for such a eminent personality. Sir has been the first to try many new therapies. He's been a teacher and a leader. And so I invite him to talk on can we treat Hodgkin's lymphoma in 3 months? It's a radical and new concept, but I think it's something that is very exciting. And we always need to keep updating ourselves and innovating. So over to you, sir. Thank you.
Thank you, Dr. Tulika. So as was introduced, I'm going to basically convince you that it's possible to treat a newly diagnosed case of advanced stage classical Hodgkin lymphoma in 3 months. So that's Sir Hodgkin. He was basically a pathologist and he did certain autopsies, and he described that 7 of those autopsies, the lymph nodes were not due to tuberculosis, and he felt that that was something else. He didn't know what they are, and that disease was later on called Hodgkin disease, and now we know that it's Hodgkin lymphoma. Interestingly, unlike many other cancers, Hodgkin is a disease of young people. It's only about 10% of people who have the disease beyond the age of 70, 20% have it above the age of 60, the majority have when they're in their prime youth around the age of 20 and 30. Traditionally, Hodgkin disease is considered as a curable disease. Yes, Hodgkin lymphoma is curable, but what we're going to see today is that all the treatment that we've been using so far is inferior, and it does not cure over 1/3 of the patients, and that's huge. But you tell the patient that you'll be cured, and if every third patient is going to relapse or not get cured, that is a huge setback. In oncology, everything is 6 months. And this is quite peculiar that whatever is the disease, the chemotherapy is given for 6 months, not 5 months, not 7 months. But is it really that everybody needs treatment for 6 months has been always a mystery to me. So my first question today to all of you is, can we cure a newly diagnosed advanced stage classical Hodgkin lymphoma in just 3 months? And that's going to be a big booster to the patient if somebody can be off treatment in 3 months instead of 6 months. My second question is, can you achieve progression-free survival of 94%? Listen to this figure, 94%. And that also after 5 years of the treatment. And this is important because, as I just mentioned, the traditional treatment of Hodgkin lymphoma that we have been using allows 1/3 of the patients either not respond or relapse. Well, if this statement is correct, then you are just having 6% of patients who may not get cured. And I'm equating progression-free survival to cure because of this data. You look at this black arrow, it's at 5 years. Hodgkin lymphoma relapses do not occur after 5 years. So if you've got a progression-free survival of 94%, that's equal to cure. My third question is, can you treat a newly diagnosed classical Hodgkin lymphoma advanced stage using a total dose of doxo just as low as 160 milligram per meter square? Is that important? Yes, sir, it is important because there is clear documentation that when you use anthracycline in the dose of more than 200 milligram per meter square, then you significantly increase the risk of breast cancer. And this is independent of the patient's age and independent of the exposure to radiation. So even if you are not using a combination therapy, even if the woman has not been exposed to radiation, just anthracycline alone in the dose above 200 allows HCA breast to develop. And you don't want that to happen in a young girl who has been cured of her Hodgkin. And my last question, and this is going to be very exciting in today's discussion, and it's probably very exciting for the discussion all over the world. It's a very new concept that I'm putting forward. Are immune checkpoint inhibitors safe in short term and long term for a curable disease? When we say Hodgkin, classical Hodgkin, newly diagnosed, young people, we're talking about a curable disease to the cure of 94%, isn't it? So are the immune checkpoint inhibitors safe in short and long term for treating a disease which affects young people? So these are the 4 questions which I'm putting to you, and these are the 4 questions I'm going to answer in next 20 minutes. Immune checkpoint inhibitors, what do? They allow your body to be attacked by your immune system. Yes, they allow the tumor or the cancer to be attacked by the immune system, which is the good part of it. But look at this. When you use immune checkpoint inhibitors, you allow your immune system to attack your body, any part of the body, absolutely any part of the body. You may develop cardiac failure. You may develop brain failure, that is encephalopathy. You may develop lung problem and may be crippled for the rest of your life, and so on. So you can see arrows going to each and every part of the body. We'll discuss this little later. Let's start with Akash. That's my first patient. 31-year-old business executive, married for 4.5 years, having a kid of 15 months. Was almost to leave to UK for a permanent job opportunity when poor fellow develops fever, loss of weight, and sweating for 3 weeks. PET showed significant lymphadenopathy on both the sides of the diaphragm, and in addition, involvement of the spleen, liver, lung, pleura, adrenal gland. Biopsy showed classical Hodgkin lymphoma. No comorbidities, no habits, no monetary constraint. Diagnosis, advanced stage classical Hodgkin lymphoma, stage 4B. What will a person at this age wish? He wishes a treatment with the highest chance of cure, that is 94%, which you just mentioned, in the quickest time, that is in 3 months, that I just mentioned. So what are your options for the treatment? A standard reply by an undergraduate student or a postgraduate student will be ABVD. Over last decade or so, we realized the complications of ABVD in the form of permanent damage to the lung by using bleomycin in 6 cycles. So Rathel approach of ABVD, which is PET guided. So wherever PET is available, and fortunately PET is available in India all over, you do a PET after 2 cycles of ABVD. And if you have achieved a complete PET negativity, then you drop bleomycin. That is called Rathel approach, with which you save your lung from permanent injury. But ABVD means every 3rd patient is going to relapse. And in India, when you have advanced stage cases like Akash, more often than a patient who has got just one cervical lymph node or one just little mediastinal enlargement, then you can imagine what's going to happen to your patients. And if you are in practice for last 20, 30, 40 years, you must have seen what kind of pessimistic approach you may have if you're using ABVD, because every alternate patient may come back to you with refractory or relapse disease. So the German protocol came, BRCOP or escalated BRCOP, which markedly increased the response rate, progression-free survival, overall survival of patients of Hodgkin lymphoma. But at what cost? I don't have to discuss that. You all know the adverse effects of Bayerkoff. Your patients may die of neutropenic sepsis. Your patients may develop second malignancy. Your patient may be permanently infertile. Except for the Germans, nobody used it anywhere in the world. Not in US, not in the rest of the Europe, not in Australia and New Zealand, not in the third world at all. I gave it to one patient 30 years ago. He died. After that, I have not touched this protocol. What has happened in the last 15, 20 years is two major breakthroughs, one of which is the talk for the day, brentuximab vedotin or etc. And ABVD getting replaced by BVAVD. A huge jump, a huge success, a great advance, as a result of which not 1/3 of the patient are going to relapse or be refractory. It's only about 5 to 10% of patients who will be left with relapse or refractory disease. And probably in the second part of the webinar today, we will have a case to discuss this. And what my job this evening is to discuss Bricard. What is Bricard? Bricard is Bayerkoff without its toxicity. Bricard is with the efficacy of BVAVD or even superior to BVAVD. And Bricard is something which I'm going to tell you probably challenges the Nivo AVD, the new kid on the block. Because to me, Nivo means allowing your disease to develop a large amount of immunological diseases for the rest of your life. What happened to Akash? Akash was treated with Bricard. PET after 2 cycles showed complete metabolic response. We gave him 2 more cycles, that is total of 4 cycles, which got over in 3 months. He moved to UK. He's off treatment for last 1 year, 9 months. A huge success story. My case 2 is Shreya. Shreya comes from a small place. Shreya is actually not my patient, my wife's patient, but I borrowed it to present to you because this case is a big triumph of Bricard therapy. 22-year-old female from Miraj. Chief complaints usual, extensive lymph nodes all over, marked cachexia, biopsy confirmed classical Hodgkin lymphoma, mixed subtype, ESR raised, LDH raised, mild anemia, PET scan showed disease all over, stage 4B. Gave Bricard, full treatment on OPD basis. The treatment is for 4 days. Patient comes, takes and goes back. She stayed in a small hotel. She took this treatment by going back to the hotel every night. PET 2 performed after 2 cycles. Again, same thing. Complete response, Dovil score 1. Complete metabolic response allowed us to give just 2 more cycles, a total of 4 cycles, treatment over in 3 months. As I mentioned, totally managed on outdoor basis. She had 2 brief episodes of neutropenia resolved with GCSF, no significant neuropathy because the dose of brentuximab used was so small. All B symptoms disappeared, her nutritional status reversed. Current status in January 26, when we last followed her up, her clinical examination, surveillance imaging shows no evidence of relapse whatsoever. Got married, shifted to Mumbai, delivered a baby recently. She's employed full-time and works with normal efficiency, and that's our Shreya today. And if you want to see, on the left side was the Shreya when she came, on the right side is Shreya today. A huge success story of Bricard. My case 3, without going into too much of details, Mahi belongs to Surat. And maybe her basic oncologist may be listening to this talk today. Most of the treatment was carried out by him, only guided by me. That's Mahi's initial PET scan. How lit up it was. And that's her PET scan just after 2 cycles of Bricard. Wow, wonderful. She just completed her 4th cycle. So now we have 15 patients under our own observation and 8 more patients who have been treated like our Surat patient by our colleagues all over the country. How do you choose a drug? Most of this discussion today will be between Nivo and brentuximab. So how do you choose a drug? Drug should be efficacious. It should have a favorable adverse effect profile. There should be an ease of administration and it should be cost effective, isn't it? These are the 4 things you look at using in any protocol. German Hodgkin study group came out with this study HD21, which was remodeled escalated Bayerkoff. And they remodeled it to Bricard because they realized that nobody in this world is going to use escalated Bayerkoff. So they modified it to Bricard. This was to overcome the adverse effects of escalated Birkhoff. And that's what they did. The backbone of doxocycloetoposide was retained. Brentuximab replaced bleomycin and vincristine. Two drugs were replaced by one, so that the toxicity to the lung and neuropathy was taken care of. Dacarbazine replaced procarbazine. So there is less toxicity to the gonads and less genocide. And Dexa for 4 days replaced prednisolone for 14 days. So a very bad protocol, escalated. I call it a bad because, as I told you, one patient I used, he died. And I didn't have guts to use it anymore. And nobody in the world uses this. Now even Germans have given it up. They also use Bricard rather than escalated Birkhoff. So that's the whole protocol, comparing the two, Birkhoff here, Bricard here. We'll not go into the details. The protocol is there all in the literature and on the net. 1.5 years ago, Lancet 2024 published the whole data of Bricard. It's a phase 3 open label, multi-center, to look at the efficacy and tolerability of a PET-guided Bricard. The PET was a necessary part of it, and it's a huge triumph because if you use PET, you can de-escalate your treatment to 4 cycles instead of 6 cycles. And this is the last update on this Bricard, which was presented 2 months ago in December 2025 in ASH meeting. So this is the final analysis, publication number 152 of Bricard in Hodgkin lymphoma. 1,500 patients between the age 18 to 60, randomly assigned to two protocols, Bricard versus escalated Birkhoff, PET guided, where after PET 2, which is done after 2 cycles, if the PET is negative, you give only 4 cycles, not 6. So that's what it shows. 2 Bricard, PET negative, only 2 more Bricard. 2 Birkhoff, PET negative, only 2 more Birkhoff. And if at the end there is any residual disease, then radiotherapy to that. Remind you, this was done to basically take care of the toxicity of escalated Birkhoff and to show whether Bricard is less toxic and therefore user-friendly. It was not meant to show that it is more efficacious. But look at the surprise, Bricard was more efficacious. Progression-free survival at 5 years was almost 93.5% versus 90.5% with escalated Birkhoff, with a hazard ratio of 0.66. So this was incidental advantage. Overall survival at 5 years, identical, both 98%. What's most interesting is this, 64%. That means 2 out of 3 patients. The interim PET scan after 2 cycles was negative, and therefore they needed only 4 cycles. And this is one of the major triumph of Bricard, that you don't have to give 6 cycles to 2/3 of the patient. Side effect profile, less thrombocytopenia, less neutropenia, less infection, less organ toxicity. As a result of which, less requirement of red cell, less requirement of platelet, less peripheral neuropathy, and less gonadal toxicity. Young people, 20s and 30s, when you're giving them a protocol to cure them, you don't want them to become infertile. Males, 85.6% of the patients recovered their fertility. Females, 95.3% recovered their fertility. So this study continuously looked at their FSH and concluded this. Anthracycline exposure, because 2/3 of the patient required only 4 cycles, anthracycline exposure was 160 milligram per meter square for every 2 out of 3 patients. And therefore, Bricard was associated with increased efficacy, less toxicity, and superior progression-free survival with compared to escalated Birkhoff. So summary of Bricard therapy, superior efficacy, reduced side effect, preservation of fertility, short treatment for 3 months, and reduced complications requiring less blood, platelet, etc. Now, this is your comparison. What we did for 50 years, ABVD, what replaced it, BVAVD, and what in my mind should get replaced by Bricard. And look at this, 5-year ABVD In the Western world, 75% progression-free survival. In India, this figure is just about 50 to 60% in whoever has published so far. So ABVD should be obsolete because you're allowing 40% of patients, or at least 25% of patients, even in the Western world, to receive salvage chemotherapy, and if they are transplant fit, undergo autologous transplant. Somebody may say that BVAVD or Bricard is expensive. It is less expensive than allowing the patients to receive an autologous transplant. Look at the 5-year data, progression-free of BVAVD, 82%. No doubt, a huge jump from ABVD, but inferior to Bricard, 95%. So that's why Bricard for a newly diagnosed patient. This is ASH last year, rather 2 months ago. You got Jonathan saying Bricard may be the standard therapy option for newly diagnosed advanced stage Hodgkin lymphoma. Excellent long-term efficacy and tolerability, and supports that this should be frontline PET-adapted treatment. And this is 5 years data of progression-free survival, 94% versus 91% Bricard versus Viacom. And this is Europe. European Commission approves brentuximab together with ECADD, that is Bricard, for stage 2B, 3, 4 Hodgkin lymphoma. Approval from the European Commission. Now we come to this new kid on the block, which everybody is excited about and everybody has started using it. And I want to caution them by telling some data on the slides, which I will show you. That is Nivo AVD versus AV AVD. Nivo AVD, user-friendly. Everybody is happy. There will be no neutropenia, nothing. You don't need hematologists. You don't bother about then the counts. Okay, fine. Counts do go down with Nivo. We will just see. Infections do occur with Nivo. We will just see. And what is the disadvantage of Nivo? I will tell you. So this is recently S1826, large US. This is US. The Bricard is German, European. US phase 3 intergroup study compared Nivo AVD with BV AVD and showed that 2-year progression-free survival was a bit superior. Overall survival identical. What is important is to remember that Hodgkin disease or lymphoma is a disease of young people. And hence long-term data is required. We only have 3 years data. Nivo AVD produces increased neutropenia. You may think that checkpoint inhibitor do not do that, but it produced increased neutropenia. And the new complication, increased risk of immune-related adverse events. And I'm going to show you what that means to the quality of life, what that means with respect to the mortality. Immediate immune-related reaction, delayed immune-related reaction, short-term, long-term. All this you have to accept when you're using Nivo. Not only that, if you've got any autoimmune disease pre-existing, you cannot use Nivo at all. So you've got a patient of ITP or autoimmune hemolytic anemia or SLE or rheumatoid or interstitial lung disease, you cannot use this protocol. There's no direct comparison, but here we have a match-adjusted indirect comparison. And I'll show you this because this is very important for you to understand why Bricard is important and scores over Nivo AVD. Bricard is PET adapted. So you have a data after 2 cycles, what it shows. In Nivo AVD, everybody has to have 6 cycles. There is no PET adaptation in the data published. In fact, there was no PET done. And you know that when you use Nivo, PET cannot be trusted because it may be false positive. Duration of therapy, Bricard, 2/3 of the patient, 3 months. Here, everybody is 6 months. Survival, agreed. Survival is same for both. GCSF was mandated in Bricard. So it decreases the chance of neutropenia, while in Nivo AVD, it was not mandated. So it allowed a lot of neutropenia to take place. Anthracycline, you saved young girls from CA breast because in 2/3 of the patient, you used very low dose anthracycline. Adverse effects were Bricard were hematological. So a hematologist, it's a baby's game to manage cytopenia. While in Nivo, febrile neutropenia is okay, you can manage. What about immune-mediated problems? How do you manage them? Onset of adverse effects in Bricard is immediate and over. In Nevo, some of the immune-mediated insults occur after months and years. Duration of adverse effects, Bricard, short. While Nevo, what it does, it can produce hypothyroidism, hyperthyroidism. It can damage your pituitary, lung, heart, adrenal. You may be Cushingoid syndrome for the rest of your life receiving steroids. Or you may be diabetic for the rest of your life receiving insulin. Contraindication for Bricard, almost nil. While Nevo, if you have got a pre-existing disease, you can't use it. Immune disease, you can't use it. Now, one discussion is that Nevo is safe in elderly people. Agreed, because it doesn't cause so much of myelosuppression. Here is the data, 568 abstract, PET-guided Bricard in older people with advanced stage classical Hodgkin lymphoma, phase 2, part of the GHS Hodgkin disease 21 trial. So you've got elderly people data, which showed that yes, in about 10-15% of patients, you had to stop the treatment, but majority of the patient, it can be used even in elderly people. Now, you may like to have a real life data. This is real world experience outside Germany of Bricard therapy from Israel, one of the most trusted countries for scientific data. And the real world data, what they showed is higher complete response rate after 2 cycles, not 63%, 83%. Very little need for radiation consolidation, published by Boekman in Lancet last year. So now let's compare these 3-4 protocols. ABVD, I would say an obsolete protocol, very cheap. So if your patient belongs to a low socioeconomic group and has got no support from government or institution or other charitable trust or insurance, yes, it's the cheapest. 6 months, but at the cost of that every third patient will probably still relapse and need an expensive treatment like transplant. BVD, huge step forward, no doubt about it. Huge overall survival advantage, progression-free survival advantage, 6 months treatment. GCSF is mandated. Yes, there is some amount of peripheral neuropathy. PET scan must be added. There was no PET scan in the initial study, but we do it in the practice. Nevo AVD, the new kid on the block. Everything good, but not PET adapted. And whose problem of immune disorders created by this treatment. Bricard, it has efficacy of escalated BFCOP and it has safety of Nevo AVD. It is PAT adapted. As we discussed, large number of patients, only 3 months treatment. As we discussed, large number of patients, very safe dose of Adria. And as we discussed, can be given to patients who are young and who got immune diseases. The hidden part of treatment using checkpoint inhibitors. The hidden part because it's not talked about. Look at the publication of Nevo AVD. No mention. No talk about it. Therefore comes this blood article. Do we see the full picture of anti-PD-1 while we are treating classical Hodgkin lymphoma? It's important because this much can happen. And this is half of the body. And this can happen, the remaining half of the body. You may have to live with this tongue for the rest of your life. There's no part of the body which is not affected by your immune system. This is horrifying. Clinical spectrum and evolution of immune checkpoint inhibitor toxicity over a decade, published. Immune-related adverse effects associated with immune checkpoint inhibitor, published New England Journal. Persistent immune-related adverse effects after cessation of CPI, published. Long-term toxicity of immune checkpoint inhibitor, published. Key points, chronic immune-related adverse effects lasting for more than 3 months after stopping the treatment occur in half of the patients. These events affect almost every organ and may improve over time. Understanding of chronic adverse effects on this side will probably help you in preventing and treating them. Short-term side effect, mild, 87%, severe, deadly, 13%. Long-term, mild, 96%, deadly, 4%, persisting till the study was going on, 86%. ITP following immune checkpoint inhibitor, imagine. Diabetes after immune checkpoint inhibitor. Infertility happening because of gonadal damage after checkpoint inhibitor. So, why should we use Bricard in classical Hodgkin lymphoma first line? Actually, the question should be, why should we not use Bricard? in the classical Hodgkin lymphoma first line. So Bricard raises the bar in classical Hodgkin lymphoma, and Bricard is the clear winner. And I give you this last slide. And this is what makes probably treatment cheaper as well. I want you to look at the bottom part of it. Give Bricard 2 to everybody. Do a PET 2. If it's positive, give Bricard 4 more cycle. Because without that, you will not be curing people. If it's negative, give 2 more cycles of Bricard that we've been talking for last half an hour. And if you can't afford, then now you can escalate down to AVD 4 cycles. This can make it cost effective as well. So for poor patient, maybe this. For those who can afford, this is the best. And for those who are unfortunate to have a PET negative, full 6 cycles of Bricard. So I think this is wow. Thank you very much for allowing me to present this data to you.
Thank you so much, Dr. Agarwal. That was absolutely brilliant. And you really converted us on this amazing regimen, which is not only effective, but it is got a lot less toxicity. We see a lot of patients from the medical oncology side who have been treated on a variety of checkpoint inhibitors. And another thing that we are seeing is autoimmune hemolytic anemia. And in several of these patients, it actually can occur even a few years later. And it's very difficult to manage and needs rituximab and other agents. So, again, adding to the cost. So, that was really wonderful. And you've really set the stage for our panel discussion. So we have a very, very eminent and bright panel. I'm really looking forward to this discussion. And just for any audience members who have any questions, we have a Q&A box. So I would request you to type in your questions. And I request Dr. MB sir to stay with the panel because he will be there to answer any questions that can be directed to him or that we would like his valuable inputs. So to just introduce the panel, we have a really eminent group. I start with Dr. Riaz Ahmed, whom everybody knows. He is the director at the Max Saket Super Specialty Hospital in Saket. We have Dr. Anshul Gupta, who's with us. He is, again, an expert hematologist, and currently he's at Medanta Hospital, Lucknow. So, welcome, Dr. Anshul. Then we have Lieutenant Colonel Dr. Rajat Govind. He's at the R&R Hospital, New Delhi. So, welcome, Dr. Rajat. And we have Dr. Abhijit Fukan. He is joining us from Guwahati. So, we're very happy to have him here. And last but not least, we have Dr. Shaurya Ghosh, who is a consultant in clinical hematology at the Tata Medical Center, Kolkata. And with all of these eminent panelists, we also have Dr. MB sir, who is going to be with us in this panel. So I'll just share my slides. Are the slides visible?
Yes, ma'am.
Excellent. So we're going to have a case-based discussion, and we have several scenarios. So just some disclosures. These slides have been shared by the company, and but all the views and discussion that we have are our own. So
Interrupt you, ma'am. I mean, if you can just put your slides into presentation.
I just noticed that. Thank you.
Yeah.
Yeah. So the first case that we have is a young adult who's 43 years old, and he's got classical Hodgkins and a high IPS. So the presentation is the usual B symptoms. He's got lymphadenopathy, mediastinal mass, and there's also extranodal involvement. Here he has liver involvement. We can see he's got anemia, a low albumin, elevated white count, but lymphopenia is there. And the PET scan shows a Duvel for multiple lymph nodes as well as extranodal sites. So the IPS score is high with all of these factors, and the ECOG performance is 1. He does not have any comorbidities. So in a young patient like this, what would be the treatment approach for you? And any of the panelists are welcome to jump in.
So, if I can begin, ma'am, thank you very much for first of all allowing us to be part of this discussion in a very elite group. So the first case seems to be an advanced case of classical Hodgkin's, and both clinically with the presence of extranodal site and IPI wise also seems to be a high risk, if you can call it high risk disease. And in such a case, I think so far, I think till about couple of years back, I would have gone with the Rathel with the PET guided approach with the 2 cycles ABVD followed by 4 AVD, depending on the PET IPET 2. But I think now with the newer agents in the block, I'll be honest that in our center, since it was more of availability and logistical issues, we were sticking to the use of ABVD. But now the accessibility has improved, so now we have shifted to BVAVD. We have yet to honestly not have not used Brecard as such. It sounds promising from what Dr. Agarwal sir had just spoken a while back. But to be honest, I think BVAVD is what we are using. And in a couple of cases, in younger individuals, we've used Nivo AVD as well. So that's what we use.
Wonderful. Thank you so much for sharing your experience. Would anybody else like to comment on what they are kind of using now?
Hello, ma'am. It's Dr. Abhijit from Guwahati. So it's a pleasure being in this group, ma'am. So actually, we from here, most of the patients have a problem like financial issue is always there. So even if we are offering that brentuximab upfront, so most of the patients cannot tolerate, and around 70% patients cannot tolerate. The pain we have to bear later on when they relapse. So when I started practice 7 years back, so at that time we are using ABVD for most of the patients. Now that all the patients around, as Sir Agarwal sir has told, many of the patients are now coming up with relapse. So that is very painful for Hodgkin's lymphoma, for the younger people who we are treating. So now we are offering that treatment of brentuximab AVD. So I'm in my institute, we are preferring in Apollo, we are giving a brentuximab AVD, not Brecard, because we have not started that one. Because I am in touch with Agarwal sir, I know that can be offered, but I don't have that opportunity to start Brecard. So brentuximab AVD has been given to around 5 or 6 patients, and all are aggressive disease with high tumor IPI score. So we have selected only those patients with aggressive disease, and thankfully they all of them have done very well. And after 2 cycles, all have shown PET negativity. So definitely this is a game-changing molecule in Hodgkin's lymphoma.
And there's a patient assistance program that can sort of help.
Yes, ma'am. Yes. Patient has been offered those assistance programs also. But still, ma'am, the price at this price point, many of the patient from my part of this India is very difficult to treat. Yes.
No, we need to get these kind of products into the government schema. So let's see.
Yes.
We're doing some cost effectiveness studies on this. So if that proves to be good, then we can get them in the government programs. That is also going to be important for many of my patients as well.
Yes, ma'am. And ma'am, if the sir has shown the slides, and I'm very interested to go to that slide, like brentuximab AVD first 2 cycles, PET negative, financial issue change to AVD. So if that option is also available, that will be a relief for a few of the patients, I think. So I need to...
That was with the Brecard. So
yes, Brecard. Yes, ma'am. Brecard first 2 cycles, and then you de-escalate.
Somebody who can afford for 2 cycles but can't afford 4 cycles. So that
the people are there.
Borderline affordable patients.
Yes, sir.
But we have all kinds of patients. We have those also, the middle kind of. So what defines success in Hodgkin's lymphoma? Sir's already talked about we want to be able to cure everybody. We want a good overall survival, and we want to optimize these high IPS patients, whom I would say in India there are many, because most of our patients present quite late, and many have mixed cellularity disease. They have all the other IPS, sometimes all 7 of the criteria are there in patients. So I think in India, we do have a difficulty in many of the difficult patients that we are treating. So as Dr. MB had set the stage, we have been using an older regimen, which is a good regimen. But now that we have things that are better, I think it's sometimes we have to see how we can move on to the newer things and let go of the old. So, apart from what we've already discussed, what are your views on brentuximab in the front line since its approval? Anybody else want to comment on what their experience was?
Brentuximab, ma'am, we have used it. To be honest, it started off by using it in cutaneous lymphomas and all ALCLs, etc. So there we found that with the use of brentuximab, definitely a drug which is quite effective, but a lot of side effects, especially at least I can talk about my small little experience. We had few patients who had very bad transaminitis and very bad neuropathy. These two side effects. So the median onset of cycles would be around 2 to 3 cycles. I would say that it started off really bad. Many of the times we had to dose modify, skip a few doses as well. So, but barring that, rest about say about 8 to 10 patients of at least Hodgkin's lymphoma, I would definitely say that they have really responded well, no doubt about that. So, usable drug, no doubt about it, but we have to be careful about the adverse events. About 20 to 30%, I would say, we have to be very careful.
Right. The peripheral neuropathy is something that I think with each cycle, it's very important to monitor.
Monitor, yes.
And as soon as you suspect that it's there, you need to either, dose reduce or hold in depending on the severity, because many times it may not, recover if you continue that. So I think that's really important. It should be like, mandatory to ask pointed questions about the symptoms so that it doesn't get missed.
Yes, ma'am. And ma'am, just I want to add in my experience, like those side effects are more common in elderly. As the age group increases, the side effects I have seen that they're increasing. So people with around 50 years not able to take after 3 or 4 cycles of brand. But whereas the younger population, 18 years or like those patients I have tried, so they took generally very nicely. So younger population are taking with minimum side effects like neuropathy and all those. But elderly people, they really struggle a lot, ma'am.
So I'll take the third question. Have you observed any secondary malignancies in your patients? I mean, obviously not. We're not talking about Bren right now because secondary malignancies may take a little longer time to develop. So, what is your experience with some of these, both the conventional as well as the novel therapies about secondary malignancies in our? I think we're talking about Hodgkin. So in Hodgkin's patients.
Yeah, definitely with the conventional therapy, definitely, ma'am. We have with the use of ABVD, doxorubicin. So we have definitely seen patients coming up with myeloid neoplasms over a period of time. Some breast malignancies in women who used to be treated with those erstwhile mantle field radiations, etc. So we've seen definitely that. But the newer regimens, of course, are too early to say, and we are too inexperienced to really see some secondary malignancies so far. But with the conventional regimens, definitely it used to be a problem.
So we'll have to wait.
Yeah. Ma'am,
Yes,
good
please.
evening. I had a small question. So,
Yes.
ma'am, in your and to the other panelists as well, in your practice, have you noticed any metabolic issues with brentuximab? For example, patients developing hyperglycemias and developing metabolic acidosis, diabetic ketoacidosis, things like that with brentuximab, because we've had two patients who kind of developed this kind of thing while on treatment, which were managed. But was it like in the others' experience, has anybody noticed something like this?
So I think it's there. If I can go to the slides on toxicity, I think there is some toxicity of that. I think that's going to be maybe later on. No, not in that slide. So I'm not sure if that's something very common, but see, all drugs can have toxicity. And what we've often seen in our patients who were pre-diabetic, a lot of times when we give therapy, we have seen them go into develop diabetes, and if not noticed, then they can have these kind of metabolic problems. But again, I don't have a very large number of patients who've been on brentuximab.
So yes, ma'am. So we actually have been using brentuximab for the past, I would say, 6 years, because we had the compassionate access program initially. So we had access to the drug for quite a long period of time, and we've used it in both Hodgkins and in other CD30 positive lymphomas and malignancies. So what we had noticed was that the neuropathy was quite consistently a problem around dose 9 and 10, and then beyond that. So even in young patients, near about dose 10 of brentuximab, they would get dose limiting toxicities, neurotoxicities, and peripheral neuropathy primarily, which led to, initially we tried with dose reductions, and then we had to ultimately omit the drugs. But we've had otherwise, and apart from these two patients who developed these, I would say, kind of idiosyncratic reactions, we've otherwise had a good experience with the drug, and we've used it in all settings. Pre-transplant as a bridge, go-to regimen, salvage regimen has been traditionally brentuximab and bendamustine for patients who progressed or who had relapse after first line treatment. This was way before nivolumab was available, and yeah, and even in post transplant setting, we've used it as maintenance post autologous transplant, and also we've also used in very elderly patients as kind of a brentuximab nivolumab combination in patients who are transplant ineligible. So in those patients also, we've got some good durable responses.
Okay, so that's excellent. That's a chemo-free regimen. So thank you for sharing your wide experience. That's really good to know. And it's good to know that you've used it in elderly patients also. So that's really good. So just moving back to the slides that we have. So the BV-AVD has shown an overall survival benefit compared to ABVD. Not so much in the first 2 years, but if you look at patients over 6 years and 7 years, you can definitely see that the graphs do separate. So, and the other thing is that with the brentuximab, there's 41% reduction in risk of death. So that's really important, as well as the overall survival. And this continues even at 7 years. So there is definitely a trend to benefit in the first 2 years in the overall survival, and this continues over time. And the survival is in certain groups. The patients who were more than 40, and this overall survival benefit continued at 7 years to 98.2%. There was a reduction in death, and the reduction in death was also there in the high IPS group, which is a group that we all worry about, as well as in those with more than one extranodal sites. The Echelon study showed that another important thing is that it reduced the need for subsequent anti-cancer therapies. And this was there not only in 2 years, but also was maintained at 6 years. So at about 2 years, patients who got ABVD, they were 33% more likely to receive further therapy or transplant. And this continued even at patients who were 6 years post. And we know, as Dr. MB sir had said, that you're less likely to relapse at that point of time. So now going to the SWOG study. The SWOG study, as you all know, is the Nivo AVD, and they compared that to the brentuximab AVD. And it kind of looked like the Nivo AVD was doing better in this study, but there are some lacunae to this. It was a shorter term follow-up, not too much toxicity data, no data on secondary malignancies, though for that, obviously, we'd have to wait a lot more. And uh, the if you look at the 18 to 60 years, there wasn't too much of a difference. But when we look at patients who were older or patients who were younger than 18, there seems to be a little bit of a difference between the Nivo AVD and the brentuximab AVD. So, interesting study. As Dr. MB Sir had highlighted, the patients on the Nivo arm, there were certain patients who were excluded. So, anybody who had any prior autoimmune disease or had interstitial lung disease and other things, they were not allowed to go on the Nivo AVD arm. There were no exclusions for patients who were on the brentuximab arm, so that was interesting. And if you look at about, though here it kind of looks like at about 2 years, the results were pretty much the same. So that was not too much of a difference. Anybody want to comment on the study and how they felt about the Nivo AVD study? And are they using Nivo AVD upfront?
So, ma'am, I have used in elderly patients two elderly patients Nivo ABD in upfront setting, and it's been about 18 months now, and they're 18 months for one patient and about 12 months for another, and they're doing okay so far without any immune-related adverse events as of now. But after listening to Sir's talk and the published literature, it's quite scary. But yes, the treatment delivery was absolutely smooth. There were no issues whatsoever. Whereas with the brentuximab AVD, patients do sometimes land up with neutropenic sepsis, and the use of growth factor should be liberal. That is what we have realized. Um, but yeah, yes, ma'am. That is my limited experience with Nivo AVD.
So Nivo AVD we have not used, but brentuximab when AVD if you're using it is mandatory to use GCSF, and if you look at the SWOG study in the 18 to 60 age group, the bar actually touches the line. So basically, there's not much difference between these two products. In the pediatric age group and maybe the elderly, there may be some benefit in this, but again, as we said, we don't have long-term data and we don't have secondary malignancy data or long-term toxicity data. So, but it's good to know that we have many options, and I think it's important in different populations and in your scenario to know what is the best. So this is again the same thing, and the number of deaths in each arm were approximately the same, whether you used Nivo AVD versus brentuximab AVD. And obviously, if you're using brentuximab, it's mandatory to use GCSF with that. The adverse events, though interesting, was that even though we think of brentuximab causing more neutropenia in the SWOG study, in spite of it being very well conducted and everything, they actually had more neutropenia in the Nivo AVD. And of course, the hypothyroidism, the hyperthyroidism, and all the other issues were obviously more in the Nivo AVD arm. So this I thought was a little bit interesting that we usually worry about neutropenia with brentuximab, but actually it was found to be here. So again, it may be different in our practice, but this is what the paper says. So, looking at the safety data and comparing Nivo AVD with brentuximab AVD, we obviously have seen that there are immune-related endocrine events. What factors do you believe explains this difference, and how should you see the findings influence the monitoring and management strategies when selecting therapy for newly diagnosed advanced Hodgkin's lymphoma? So basically, I think they're asking when you have a young patient, when you have a new patient with newly diagnosed advanced Hodgkin's, what are you going to look at to select your therapy? And how are you going to monitor them while they're on treatment?
I think while if you were to choose the first line therapy in a newly diagnosed patient, I think we have to look at two, three things. One is, of course, the availability and etc. apart. But if you're looking at long-term remissions with preserved quality of life, then age is one very important factor. So if in an elderly patient, I think what the other panelists were also saying, you see, our experience with brentuximab is slightly chary. So in that case, then Nivo AVD becomes a prime kind of candidate here. Younger individuals who are able to sort of tolerate even the usual side effects and there are no pre-existing neuropathies, no diabetes, etc. In such cases, then brentuximab becomes a good candidate. But again, ma'am, I think to be really honest, Nivo AVD is a kind of a cheap and doable chemotherapy, and we have sort of started using it in our setting. And probably because there is a bias again that we have more used it in solid malignancy, so we know that the immune related adverse events, if one is prepared for and is monitoring it regularly, especially the hyperthyroidism, the autoimmune hepatitis, the mucositis, the transaminitis, etc. These are some things that we need to be prepared for. So these are the, at least these for me, these are the deciding factors.
So I think that's very nicely stated. A lot of times the choice also depends on what we are comfortable with, and I think that's perfectly legit because you have to use what you are able to manage in your scenario. And it's nice to know that we have different choices. So perhaps in older age patients, we could have a different choice, and for certain other subsets of patients or patients with different problems, we could have other choices. So if rather than just having a one regimen that was a one size fits all, we now can tailor the therapy to the patient. So I think we are definitely in a better place. And so I think this is again just highlighting that yes, this is one other option that we can add to treatments to improve our frontline therapy. Now, moving from frontline therapy to relapsed classical Hodgkin's. So we have a patient who's already received AB and has unfortunately relapsed. And this patient relapses more than a year after this. And again, we have IPS, it is about 3 years. Patient is eligible for transplant. This is the typical kind of patient that we would get who, relapses after a while and he's got, he's so here you have everything available. Youngish patient relapsed after about a year. And so what kind of salvage therapy would you think? He's not had any of the novel agents before, and where would you put brentuximab pre post consolidation? The floor is yours. What would you suggest?
So if I may answer this, so brentuximab in this situation, we in our center would be, combine with bendamustine, and we would give about 3 cycles, and then repeat imaging and see the response, and then take up for an autologous transplant. It's kind of daycare-based treatment. The toxicities are minimal, and we've had good experience with this. And then there are no mobilization issues as either. So we've been using that, and the CR rates are in the tune of I think 89 to 90% with brentuximab and bendamustine. There are other regimens like brentuximab with ICE or brentuximab with GDP that can be used. Sometimes there are toxicities of the chemotherapeutics in those regimens. And yes, ma'am. So in this situation, some people are nowadays using nivolumab or pembrolizumab as well. But again, whichever I think is comfortable with, and we would try to achieve whichever regimen gives the highest CR rate with the least toxicity, with the least problem to mobilize would be the agent of choice.
That's true. We've used bendamustine and brentuximab in that prior to transplant, and that's actually been something that we're quite comfortable with now. Any other comments before we go to the last case, or anybody else have any questions or comments on this case?
Anyone used brentuximab and nivolumab both together in such cases?
So I think that's a interesting combination, but I think that would be something I would maybe leave for like somebody who had a very
Further
poor
lines.
status or was very elderly, or where I didn't want to use any chemo. Perhaps. I mean, that's my suggestion. And Dr. MB, what would be your viewpoint on using Nivo and BV together?
Do one thing, you finish off your 3 cases, then I've got about 2 minutes of comments. I'll give you my comments.
Okay, lovely, sir. Oops, did I skip something? Sorry. So this is a patient who's relapsed after 2 lines, and he's transplant ineligible. So he's elderly. He's had multiple lines of chemotherapy, and now he's relapsed. He also has certain comorbidities, hypertension, COPD. The IPS at the relapse now is 4. And what would you do for this patient who's had ABVD, he's had DAP, he's had gemcitabine, vinolorpine, and he's transplant ineligible?
Ma'am, this patient would benefit from from a chemo-free approach, like maybe brentuximab single agent or brentuximab with nivolumab. Now, brentuximab single agent has, I think, an overall response in the range of 70%. Uh, I think this was single agent. Yeah. So it ranges from in that range, and the if we combine it with nivolumab, the responses can go higher and they are more durable. So we've had patients who've almost been in CR for about 3 years now on brentuximab. Very old, frail patients who are not eligible for any other treatments, and with acceptable toxicity, with not very significant toxicities or requiring admissions. So that should be the goal in patients who are frail and not fit for aggressive treatments.
Right. So the monotherapy also can be quite effective, and the duration of response is about 6 months with this as a single agent, and in the estimated survival at 12 months is about 86%, and some of these patients did go on to get transplant. So maybe if it was ineligible due to some comorbidities that could improve, so that was seen. And the other good thing was that the median time to response is 6 weeks. So that is good. So if you have a patient who's very sick, then that's very important. And the median time to CR was 12 weeks. This it's like even in monotherapy, we have very good response rates, and the toxicity is very manageable, which is very important for frail patients who are multiply treated. And the last case we have is a high risk patient who has relapsed within 12 months. Patient again has had multiple lines of therapy, multiple lines of salvage, and now has been taken up for the transplant, and again with a high IPS, fortunately no comorbidities. So for this patient, because he's relapsed in less than 12 months, and also has, I think, some extranodal disease, um, uh, and B symptoms. So these are patients where we would want to do the post-transplant maintenance or consolidation, if you want to call that. And that's where this really shows a benefit in these high-risk patients. And it reduces by giving this maintenance. So if the patients have several risk factors like an early relapse, extranodal disease, B symptoms prior to the transplant. So having two or more of these symptoms, definitely these patients have earned the maintenance, and these patients are the ones who will benefit the most from this maintenance. Now, we had already talked about the neuropathy, which was beautifully brought up by my colleague, and the good thing is that if you are able to reduce the dose or stop the peripheral neuropathy, in about 90% of patients, it will eventually recover. So that, and the complete resolution can be in 73%. But I think one of the most important things is as soon as it starts, not to allow it to get to be really bad, and make a decision on either stopping the therapy or reducing the therapy at the earliest point. So I think this point we've already discussed, and I think we have a lot of questions coming in the panel. So I think we'll end off here because this is something that was already nicely highlighted. So I'll stop sharing and we'll go to our Q&A box because I think we have some questions. I saw some questions somewhere. Okay, we have some questions in the chat. If all okay, so one question from Bhargav Vepumala is mostly all the adverse events are grade 1 or 2 or easily treatable. Okay, well, sometimes they are, but sometimes they're not. But interesting point. Have used BV-AVD safely in Hodgkins with HLH. Okay, where use of Nivo may not be feasible. Okay, so anybody want to comment on any patients with HLH?
I would echo those thoughts, ma'am. Yeah, we've faced this issue in the past, and we've had issues with nivolumab and then post-transplant HLH. Those are really tough patients to handle. So if somebody is presenting with HLH, better to avoid IPIs.
Okay, so we anyway don't really use Nivo, but that's a good thing to for sharing. That's a very good point. Thank you. And then Apurva asks if longer term data is emerging, do you anticipate BV-AVD retaining its position as the standard frontline? Well, I think Dr. MB would say that BRICAD is probably a better one, but that's there. I only see 3 questions. Are there any other questions that I'm missing or no? Okay, so then I will hand over to Dr. MB, who's been waiting to give his comments. So please.
Well, thank you, Dr. Tulika and the panelists. You had a wonderful discussion, beautiful 4 cases we brought up. So I made some notes from the discussion that has taken place. First of all, about the HLH. Nivo can lead to HLH. In fact, I think Dr. Gupta's case was like that. We had discussed this in Mumbai Hematology Group. I had a patient who developed HLH on Nivo. In fact, I had not thought of it. It was PUO. And then while searching for the infection, we landed up with very extremely high ferritin and then soluble CD25 and then full-blown HLH on the bone marrow. This patient succumbed. So HLH is a difficult disease to treat, and it can be a complication of Nivo because it's an immune-mediated complication. And when I presented this case, Dr. Verma from Lucknow presented a case of encephalopathy following Nivo, and that patient is virtually sort of brain dead, vegetative. Another case presented of Cushing syndrome, where patient developed hypotensive crisis and had to be pulled out of that with a lot of efforts because of the adrenal gland getting damaged. Now, lifelong, that patient has to be on adrenal replacement therapy. So it's, when you're using Levo in medical oncology, we are often giving it to people who got a short life left. When you're giving it to Hodgkin disease for 20s and 30s and got a curable disease, you got another 70, 60 years of life in front of you. So late complications can be quite a disaster. One has to be careful about that. We had a lot of discussion about neuropathy. It is mandatory that each time a patient comes for the next dose, you ask patient, we ask for so many things in other diseases. Here you ask about the symptoms of neuropathy. If you're not very sure, do the EMG now conduction. Those who are baseline diabetic and alcohol, you can do a baseline EMG now conduction. Then the dose of brentuximab, 1.8 for 3 weekly, 1.2 for 2 weekly, and whenever there are symptoms of neuropathy, grade 1, you can drop it to 0.9, you can drop it to 0.6. So it's not that you have to drop the drug totally. You can drop the doses and you can still achieve the results. There was a discussion about liver. Yes, brentuximab is hepatotoxic. You need to look for the bilirubin, SGOT, IGPT each time the patient comes for the next dose. There was a talk about metabolic complications, and one of the panelists talked about sugar and diabetic encephalopathy. It is a complication of brentuximab. You have to look out for the sugar. You have to look out for the electrolyte disturbances. Sodium can go down, potassium can go down, phosphorus can go down. So sugar, electrolytes, liver function all have to be monitored. If you have that, liver people talk about that chug class A, B, C, child hook
Child.
class A, B, C. So if you have A, then you can probably use brentuximab. If you have B, you should be very careful. C, it is contraindicated. Unlike that, kidney, there is no problem. Even if you got a patient of CKD with creatinine, or even you got an anuric patient, you can use brentuximab in the full dose. So that's about the metabolic and liver and kidney. There was a talk about BV and Nivo being used. Remember that Hodgkin disease without chemotherapy cannot be cured. Should never forget this simple statement that no amount of brentuximab or Nivo can cure a patient of Hodgkin disease. So if your patient is so disabled that cure is out of the question, then only you should stick to only Nivo and BV. Every patient who has got a chance of cure, you need some chemotherapy. Unless the heart does not permit, doxorubicin is the best chemotherapy. And if the heart does not permit, then DTIC, dacarbazine, is the best next chemotherapy. So even if you use BV-Nivo with DTIC or BV-Nivo with doxorubicin, depending upon the cardiac condition, you are sort of giving some chance of cure to the patient. So elderly people, cure should not be written off, depends upon what kind of drug combination they can have. About Tulika asked about what protocol we use for preparing a patient for the transplant. I would like to re-emphasize, if you got a 94% progression-free survival with the protocol that we discussed today, you will have only 6% of patients where you will be discussing these questions. So Hodgkin disease relapse situation is disappearing from the Western world. So there is no research going to take place. And therefore, you've got all the things at your disposal. You may use whatever you want. In India, you see these patients left and right because even ABVD is not properly executed and patients come late as you described, and the patients are of bad Hodgkin, mixed cellularity, EB virus positive, all that kind of stuff. So we do have these kind of patients. You have to use one of the two, brentuximab or Nivo. So if you are not use either of the two in front line, then you've got a choice. If you use one of them in the front line, then obviously it will be the other one. Plus, you have to have one chemo. I think I will be declining a use of only BV with Nivo in this setup because you need a chemo to get a good response. So some kind of chemo with either Nivo or brentuximab, whatever you're not used upfront. Do I have any other remarks? I think that's it. And don't forget allotransplant in India. That remains the last resort and the cheap resort for some of our patients.
That's true. That's true. So since you've been highlighting the BRICAD regimen, Dr. Riaz Ahmed, one of our panelists, has put in the chat box that he wanted to know the role of radiation therapy in patients with bulky disease post BRICAD. So if a patient has very bulky disease, is BRICAD sufficient, or do we still see patients who need radiotherapy post BRICAD?
So BRICAD protocol, if you see, your EOT PET scan decides whether there is a metabolically active disease left. And if there is, the next step is to do the biopsy. If the PET scan is positive, I don't know whether you have now access to ctDNA in Hodgkin lymphoma. Now we've got a lab in Mumbai that does ctDNA also. So PET positivity, ctDNA, all this put together, SOS biopsy. If you're convinced, then you need to radiate. So EOT radiation is required for a small percentage of patient. It was a substantial number in the German study. In the Israel study, peculiarly, it was only 1 to 2% of patients who needed EOT radiation. So yes, you want to cure the patient. That is a must. So if you've got residual metabolically active disease, got an access to ctDNA, then ctDNA, and then biopsy, because it will be false positive PET. So then biopsy, question remains, you may not hit the area, biopsy may be difficult, you may not be able to perform the biopsy. All those practical issues are there. But when in doubt, we just wait and watch and do a repeat PET when nothing is very clear cut. But otherwise, if clear cut case, radiation is a must.
So that,
Thank you, sir.
thank you so much. So do any of the other panelists have any questions for Dr. MB? I think this is a great opportunity.
Ma'am, I had one question for sir and also for you.
Yes.
We've also noticed a lot of CMV reactivations in patients getting brentuximab, CMV and some difficult infections, even post-treatment. So, I mean, we usually don't suspect uh, early on when the patients come in with fever, but then CMV, then some other viral reactivations, EBV also in a patient, tuberculosis in another. So these things have this was again not in a Hodgkin's patient. That this was in a T cell lymphoma patient, but then we've got CMV reactivations in some Hodgkin's patients as well. So, question two, sir, have you noticed such infections occurring more than often, more commonly than you would expect in patients getting brentuximab?
Hodgkin disease itself has a severe impairment of cellular immunity. So there are patients presenting with tuberculosis right at initial presentation, may have Cox and Hodgkin. Then the impaired cellular immunity persists for a very long time, even after you have cured patient of Hodgkin lymphoma. And on top of that, you're using these drugs. Our prophylactic protocol includes Bactrim DS, acyclovir, and fluconazole to all the patients. I must accept that we are not looking for CMV in all the patients. We are not giving any kind of prophylaxis. We are not searching for it, but patients who develop cytopenia or some kind of suggestion clinically, colitis, etc., then probably we take up the CMV viral load. So maybe we are missing, but we have not looked very closely to the CMV infection in this setting.
Mm. No, that's interesting to note, and I think it's something that all of us should be looking out for. But again, CMV can be fairly tricky. We've had patients who got APML and then they got CMV, and so I mean, like it doesn't always have to be related to the drug. Sometimes they can have patients who might have some other immune deficiency. I remember one patient, ALL on maintenance, developed CMV, and we were really surprised because patient was not even neutropenic and was just on very standard maintenance. So sometimes CMV can be a little bit of a surprise, but again, it's important to note that anything can happen and we should be observant and monitor the patients because ultimately patient safety is important. So I think this has been a wonderful discussion, and as always, Dr. MB's insights have been really, really important to us, and I think we're really at a very pivotal point where we are making a change. Over the last few years, there's been a complete change in the way we treat myeloma, CLL, etc., and I think Hodgkin's was long overdue for it. And with the data that we have and the safety data as well as the efficacy data, I think this is a time where we need to make a concerted effort to change the way that we manage Hodgkin's. And as I said right at the beginning, when you have a relapsed or refractory Hodgkin's, it is an absolutely miserable disease. And if by doing better upfront therapy, we are spending the money where it is going to actually make the biggest impact in not only the life but the quality of life of the patients. And I think this is really important that even though it is expensive, we need to work on getting access and treating our patients once in a way that they don't need to have any further therapy in the future. And I'm doing a health economic assessment on looking at BV. So let's see what that shows out. And with that, yes, Dr. MB, go ahead.
Health economic assessment. I forgot mention one very important thing. The slide that I showed you, Bricard, 2 cycles. PAP gives you 1 cycle free. So you pay for the first, second free, interim PET scan negative, 4 AVD.
Amazing. Amazing.
Absolutely the cheapest way to treat a poor Hodgkin lymphoma, just paying for 1 dose of brentuximab.
And what we've seen at AIMS, which is a government hospital where now we mostly get patients who are below poverty line and on government schemes, neither the government programs pay for relapse therapies, nor does the patient have not only the financial, but neither the social bandwidth to go through all of this all over again. So I think it's really nice that we now have options and we can select better therapies upfront and delay the time or prevent the need for any further future therapy. So very, very exciting. And I would like to thank from the bottom of my heart all the excellent panelists who shared all their experience and their gems of wisdom. And as always, thank you so much to Dr. MB sir and to the organizers. And that's it. So thank you. Good night. And hopefully we'll have another exciting meeting soon in the future. Thank you, sir. Thank you, everyone.
Thanks to Professor Tulika. And thanks to Takeda. Okay, bye-bye.
Thank you so much. Thank you so much, ma'am. And thank you so much, sir, for such a wonderful session. And thank you so much for our wonderful panelists for joining the session and for their wonderful insights. So with this, we close the session for today and have a very good night. Thank you so much.
Thank you, everyone.